Today we'll be discussing quick revision series in medicine for endocrinology subject. So this quick revision series will be useful for competitive exams like NEET, TNSET, etc. So before going, we'll discuss some basics. The entire concept of endocrinology is based on the concept of feedback. So we know very well feedback. A particular step in a process will inhibit the previous step or stimulate the previous step. So in endocrinology, pituitary is the master gland, master endocrine gland. It secretes most hormones which control other endocrine glands. Above the pituitary, we have the hypothalamus, which controls the pituitary by secreting, releasing hormones or inhibiting hormones. So that's where hypothalamus comes into play. The next will be pituitary. So the hypothalamus acts on the pituitary by means of releasing factors, or there can be inhibiting factors to reduce the inhibition. The pituitary, especially the anterior pituitary, secretes some hormones which act on the other endocrine glands below, like the adrenal gland, the thyroid gland, the gonads, to make them secrete hormones. So for example, adrenal gland secretes cortisol, it secretes mineralocorticoid, aldosterone, and sex steroids. These are the three hormones secreted by the adrenal cortex. The adrenal medulla, the inner part of the adrenal, secretes epinephrine. So these are the four hormones which are produced by the adrenal gland. The thyroid, we know it secretes T3 and T4, thyroxine. The gonads, they secrete they secrete testosterone or estrogens, as the case may be. So these are the final steps which come out of the endocrine glands. Now these hormones in turn, they act back on the pituitary or the hypothalamus to reduce their secretion. Which means whenever a particular hormone is produced in excess, these hormones act back on the pituitary or hypothalamus to reduce their own secretion. On the contrary, when the secretion of these hormones is low, they stimulate the pituitary or hypothalamus to produce more. So this is the basis of the feedback which functions in endocrine system. So most of our understanding in the subsequent discussion will be based on this basic concept. This is a more detailed picture of the hypothalamo-pituitary endocrine axis. If we are discussing specifically about adrenal gland, we tell that axis as hypothalamo-pituitary adrenal axis. If we are discussing about gonads, we tell about hypothalamo-pituitary gonadal axis. So likewise, for every endocrine gland, we have such things. So the important endocrine glands which we will be discussing will be the adrenal gland, the thyroid gland, gonads. So as I said, everything starts from the hypothalamus, acts on the next level, which is the pituitary. The pituitary has two parts, which is anterior pituitary and posterior pituitary. The posterior pituitary is very easy to understand because it secretes only two hormones. One is oxytocin, second is vasopressin. Vasopressin is also called as antidiuretic hormone. So only these two hormones are produced by the pituitary. Oxytocin we will not discuss here in medicine. So vasopressin we will discuss it sometime later. Now anterior pituitary is more important because it secretes 6 hormones. So one is growth hormone. Next is thyroid stimulating hormone, adrenocorticotropic hormone, FSH, LH, These two together are called as gonadotropins. And the sixth anti-repituitary hormone is prolactin. Now, growth hormone is a standalone hormone produced by the anti-repituitary. It has few functions. Now, this TSH acts on another endocrine gland, which is thyroid gland. ACTH acts on another endocrine gland, which is the adrenal gland. Not the entire adrenal gland. Okay, we'll discuss that later. Adrenal gland. FSH and LH, they act on gonadotropins. They are called gonadotropins because they act on the gonads. Prolactin, again, it can be taken as a standalone hormone. It functions on the mammary gland to produce milk, to produce lactation. Now, this is about the anti-repituitary. I already told you there is a hormone, there's a gland above the anti-repituitary, which is hypothalamus. It controls anti-repituitary in turn by either releasing or inhibiting these hormones. So the anti-repituitary hormones are the stimulating hormones. The hypothalamic hormones are the releasing hormones. So we have releasing hormones for each. For example, TSH is released or controlled by TRH, that is thyrotropin releasing hormone. ACTH in turn is controlled by CRH, corticotropin releasing hormone. This FSH and LH are controlled by GnRH, gonadotropin releasing hormone. Prolactin is special because it does not have a stimulating hormone, it has only an inhibiting hormone. That inhibiting factor or hormone is dopamine. So dopamine is produced by the hypothalamus. It inhibits prolactin secretion from the anti-repituitary. This relationship is very important because whenever we are giving a drug which is containing dopamine, it inhibits prolactin secretion. When we give dopamine antagonist, for example, we have few dopamine antagonists, for example, metoclopramide, or we have the antipsychotic drugs. Metoclopramide is a drug given in vomiting. We have many antipsychotic drugs like haloperidol, risperidone. All these are dopamine antagonists. When dopamine is antagonized, prolactin may increase. Okay. So similarly, we have some drugs called as dopamine agonists. For example, bromocriptine, or cabergoline. These are dopamine agonists, so they inhibit prolactin. They are used in hyperprolactinemia. Okay, so if you understand this dopamine and prolactin concept, you can understand about many antipsychotic drugs, antidopaminergic agents, and the dopamine agonists. So that is what is given here. See, thyrotropin releasing hormone produced by the hypothalamus. It stimulates the thyroid stimulating hormone. That TSH acts on the thyroid gland to release T4 and T3. CRH is corticotropin releasing hormone. It comes from the hypothalamus. It stimulates the pituitary to produce ACTH, which acts on the adrenal to produce cortisol. Remember the word cortisol, not other hormones. Only cortisol is under the influence of ACTH, not the other hormones. We have GnRH, gonadotropin releasing hormone from the hypothalamus. It acts on the anterior pituitary to release gonadotropins, that is LH and FSH, which acts on the gonads. And growth hormone is also important because it has two things. It has both the stimulating hormone, that is growth hormone releasing hormone. Also it has growth hormone inhibiting hormone. So growth hormone releasing hormone, it's called as somatomedin. It stimulates the anterior pituitary to release growth hormone. We have somatotropin inhibiting factor also. It inhibits growth hormone. So growth hormone has two action. Like growth hormone has a dual control from the hypothalamus. It is controlled by a releasing hormone as well as an inhibiting hormone. Whereas prolactin has only an inhibitory mediation from the hypothalamus, which is dopamine. So this is in detail about the hypothalamo-pituitary gonadal axis. Hypothalamo-pituitary endocrine axis. So another bit more detail about the relationship between the hypothalamus and the pituitary. One, these two are connected by a portal circulation. One portal circulation is in the liver and the other portal circulation is in the hypothalamus. The second important concept in the connection between hypothalamus and pituitary is about the stalk. Stalk connects the hypothalamus with the pituitary. So what happens when something compresses the stalk? For example, there is a growth in the pituitary, or there is some external mass which is compressing the stalk. When the compression is there, obviously the impulses from the hypothalamus find it difficult to reach the anterior pituitary. So in turn, what happens? Most of the hormones become low because releasing hormones are not there. So most hormones decrease because of the absence of releasing hormones from the hypothalamus. But also remember, dopamine also reduces. The supply of dopamine also reduces from the anterior hypothalamus to the anterior pituitary. I told you dopamine is the inhibitory hormone for prolactin. So when dopamine is reduced, prolactin will increase. So when there is a mass compressing the stalk between hypothalamus and anterior pituitary, most hormones decrease but prolactin increases. So one of the reasons for hyperprolactinemia is something called a stalk effect. So that is why this small anatomical factor is important to remember. So we discussed about the feedback, we discussed about the hypothalamo-pituitary endocrine axis, and we discussed about the complex relationship between hypothalamus and anterior pituitary. Now this is again a full summary. So the cells in the anterior pituitary which secrete ACTH, they are called as corticotrope. The cells which secrete growth hormone are called somatotropes. Those that secrete prolactin are called lactotropes or mammotropes. Those that secrete thyrotropin, TSH, they are called as thyrotropes. And those that secrete FSH or LH are called as gonadotropes. Okay. So we discussed their end organs also and we discussed their function also. So another important physiological fact about secretion of pituitary hormones is either they follow a pulsatile pattern or they follow diurnal variation. So pulsatility, one important example for pulsatile secretion is GnRH. See, in the hypothalamus, gonadotropin releasing hormones are produced in pulses. They are not secreted always, they are secreted only in pulses. When GnRH is secreted in pulses, the FSH or LH is also secreted in pulses, hence we have the particular effects in gonads. Okay, so GnRH comes in pulses. But consider another hormone, that is cortisol, which is secreted by the adrenal cortex. Cortisol follows something called as diurnal variation, which means there is fluctuation of the levels between the day and night, which means there is a particular maximum level at a particular time of the day and there is a minimum level in another time of the day. This is also very important to understand another concept of endocrine investigations. So if you see this clock, when does cortisol secretion become high? It peaks at 8 a.m. So you know very well cortisol is a stress hormone. So when is stress more? At the early part of the day, usually at 8 a.m. when many people start to work. So the maximum level of the stress hormone or cortisol is at 8 a.m. And you can see when is the trough level. It becomes very low at around this time, 11 o'clock to 2 o'clock. So around at midnight. So it is 11 p.m. to 2 a.m. is the trough level or the minimum level of the hormone, or that is around the midnight level. So we understand that The stress hormone or cortisol level is more in the early morning and it is low in the midnight. Why this early morning midnight difference is important in cortisol is we normally expect cortisol to be at its peak in the early morning. So suppose if its level is very low, if the cortisol level during our assay is very low in the morning time, it means cortisol is not produced. So there is a deficiency. Cortisol deficiency is called Addison's disease. On the contrary, we normally expect the cortisol level to be very low in the night. But if the cortisol level during the midnight, if it is high, we definitely understand that the cortisol secretion is high. So excess cortisol secretion is called Cushing syndrome. So the presence of low levels of a hormone at a time when it is expected to be high indicates deficiency of that hormone. Example, cortisol, Addison's disease. When a particular hormone is expected to be low, but it is very high in that particular time, it indicates excess of that hormone. This is called Cushing syndrome. So if you understand this pulsatility and if you understand this diurnal variation, only then you can understand how different hormonal assays are understood. So this is another physiological factor. So another important concept of endocrine testing is stimulation test versus suppression test. So the high versus low, it's what just we discussed. So if a particular hormone is expected to be high in a particular part of the time, but instead it is low, it means the hormone is definitely low. If a particular hormone is expected to be low, but it is high in that time, it means the hormone secretion is high at that time. Example, Addison's versus Cushing's. Now, what is stimulation versus suppression? We can take the same example. So, what is Cushing's? Cushing syndrome is excess of cortisol. So when do you say cortisol is excess? One, when its random level is high, or its level is high when it is actually expected to be low in a particular time. So I told you cortisol, the trough levels or the lowest level is seen in the midnight. So instead of cortisol levels being low in the midnight, if it is high, it definitely means Cushing syndrome is there or cortisol is excess. So that's why we measure midnight cortisol, especially midnight salivary cortisol. So if the midnight salivary cortisol is high, usually midnight cortisol has to be low. So if the midnight salivary cortisol is high, it definitely indicates cortisol is high, it is Cushing syndrome. Whereas what happens in Addison's disease? Addison's disease is nothing but deficiency of cortisol. Means its level has to be low when it is actually expected to be high. Cortisol level is normally high in the early morning 8 a.m. But if the 8 a.m. cortisol is high, if the 8 a.m. cortisol is low instead of being high, it definitely means cortisol is low, so Addison's deficiency is there. This is one level, or we can take this step as the screening test. So the high versus low diurnal variation can be used to understand the screening. It's a screening test. How will you confirm is stimulation and suppression. Here is where your feedback, the hypothalamic pituitary axis comes in play. So in Cushing syndrome, the hormone is excess. When do you actually say it is excess? When it cannot be suppressed by feedback inhibition. So cortisol is produced by the adrenal cortex. What stimulates the adrenal cortex? The adrenocorticotropin hormone from the anterior pituitary stimulates the cortex. So we say that Cushing syndrome is there when it cannot be suppressed. So what suppresses the pituitary? Exogenous steroid suppresses the pituitary. Example, dexamethasone. Dexamethasone is a steroid. It's a corticosteroid. It's an exogenous steroid. It's given from outside source. So when an exogenous steroid is given, it suppresses the anterior pituitary. It suppresses the ACTH secretion. So when endogenous ACTH reduces, endogenous cortisol reduces. So that is the basis of something called ONDST, overnight dexamethasone suppression test. So it is sort of like a confirmatory test. So when we give dexamethasone in the night, its level has to get suppressed. Cortisol level has to get suppressed in the morning. If it is not suppressed, it definitely means cortisol is high, Cushing syndrome is there. An even more better sensitive test than overnight dexamethasone suppression test is LDDST, low dose dexamethasone suppression test. But this is different from high dose dexamethasone suppression test. We'll see that shortly. So this is the basis of suppression test. Likewise comes for deficiency. So when a hormone is deficient, when do you say a hormone is deficient? When it cannot be stimulated by the anteripituitary. So cortisol, again, ACTH stimulates cortisol secretion. So in Addison's disease, we can test by giving corticotropin. Or sometimes it's called as cosyntropin. Different brands vary. So cosyntropin or corticotropin stimulation test can be done. We give ACTH by a drug, exogenous injection. We expect the cortisol to rise. If the cortisol does not rise and cortisol remains low, it means definitely cortisol is low. So this sort of confirms Addison's disease. Right? So this is the important basic. So if you understand this basic, you will never get confused. So in Cushing's, random levels or midnight levels will be high instead of being low. How will you confirm? We try to suppress it by giving dexamethasone, but the cortisol level cannot be suppressed. In Addison's, there is deficiency of cortisol. There is deficiency especially at 8 a.m. when the levels are expected to be high, and it cannot be stimulated when we give ACTH exogenously. Likewise, we can discuss about another hormone, which is growth hormone. Growth hormone, when it is deficient, it leads to dwarfism, etc. And growth hormone, when it is excess, it leads to two diseases. One is gigantism, another one is acromegaly. Remember, there is only one anabolic hormone in the body, which is insulin. The function of insulin is to store glucose as glycogen in the liver. It stores fatty acids as lipids. It converts amino acids to proteins. All other hormones like growth hormone, cortisol, thyroxine, glucagon, all these are catabolic hormones. So they try to increase the level of glucose. They break down glycogen and convert it to glucose. So one of the function of growth hormone is to increase glucose in the body. That glucose inhibits growth hormone. This is the basis of feedback. So in acromegaly, what happens? Growth hormone is high. Growth hormone acts on the liver to produce a substance called insulin-like growth factor. Even though IGF is called insulin-like growth factor, even though it is called insulin-like growth factor, this does not cause hypoglycemia. Please remember that it's a different one. So actually glucose increases. That's the final one. Even though insulin-like growth factor is high, it does not act directly on glucose. So finally, growth hormone, it leads to increased glucose. This increased glucose in turn should suppress the growth hormone production. Now what happens in acromegaly? Growth hormone is excess, so we cannot suppress growth hormone despite giving glucose. So in acromegaly, we follow a test called as glucose tolerance test. So in glucose tolerance test, we give glucose. Glucose has to suppress the growth hormone, but in acromegaly, giving glucose does not suppress the growth hormone. Now what is the opposite of this test? Inhibition test. It is done in dwarfism. So in dwarfism, GH is low. So we expect glucose to be low, peripheral glucose to be low. When glucose is low, it has to stimulate the growth hormone. That is what is expected. So how can you reduce the glucose by giving a test? By giving insulin. So in dwarfism, GH is already low, growth hormone is already low. So we confirm that by suppressing blood glucose by giving insulin. We give insulin to suppress the glucose level. When glucose reduces, normally growth hormone should increase. But in dwarfism, growth hormone is absent. So giving insulin or causing hypoglycemia will not increase growth hormone secretion. So giving insulin is like a stimulation test. Okay. So in dwarfism, we follow insulin tolerance test. So in dwarfism, giving insulin and causing hypoglycemia does not stimulate growth hormone. Whereas in acromegaly, giving glucose will not suppress growth hormone secretion, right? So this is the place where about the suppression test and stimulation test comes into play. Think of suppression test in cortisol as well as growth hormone, right? So now we will come to discussion of individual hormones. There is something called as panhypopituitarism. So panhypopituitarism is all the anterior pituitary hormones are low, which means there will be low growth hormone, low thyroxine due to low TSH, FSH and LH will be low due to FSH and LH will be low. So gonadal function will be affected. Cortisol will be low because ACTH is low. But if there is a stark effect, we expect prolactin to increase. So we will discuss about the features of individual hormone deficiencies. So what does growth hormone deficiency cause? So growth hormone deficiency causes dwarfism plus other symptoms, because when growth hormone is low, glucose is low. So there will be poor concentration, hypoglycemia is very frequent. Some changes occur in the body composition. There will be increased body fat mass, there will be central fat deposition. So they will be very obese, but the muscle mass will be low. That's what is decreased lean body mass. So they will have low muscle but more fat. They will be short. Okay. And this is what we discussed. In growth hormone, it increases IGF-1 levels. So IGF-1 will be low. This is sort of a screening test. But what growth hormone does finally? It causes hypoglycemia. So when we give insulin, it fails to increase growth hormone. So this test is called insulin stimulation test. So in dwarfism, low IGF and insulin stimulation test fails to stimulate growth hormone. It's enough if you remember these things. So how will you treat? By replacing growth hormone. So what happens when growth hormone becomes excess? So we just discussed growth hormone excess causes two diseases. One is gigantism, another one is acromegaly. Both are nearly the same. Gigantism is increased growth hormone which occurs before epiphyseal fusion. Acromegaly is the same growth hormone excess which occurs after epiphyseal fusion. So in gigantism, they will be very tall. In acromegaly, instead of being tall, they will be broad. So the broad features. So what is the screening test? IGF-1 levels will be high. And I told you, we are doing a suppression test. Suppression of growth hormone is by giving glucose. So oral glucose tolerance test is the test. So these questions are frequently asked in many exams. Okay. So our discussion was mainly about acromegaly. So this is gigantism. It's a picture taken from Harrison. He is very tall, as well as he had this he has these broad features. Okay, so we discussed about the first anti-pituitary hormone, which is about growth hormone, what happens in its deficiency, what happens in its excess. Now the next thing is prolactin excess. Excess of prolactin is called as hyperprolactinemia. Before that, a short note. So while discussing about anti-pituitary hormones or in any hormones in total, what are the causes of usually deficiency of a hormone? The gland is destroyed. So how all can a gland be destroyed? When there is a trauma to the gland, when there is an infection to the gland, when there is some autoimmune disease, lymphocytic infiltration of the gland, so autoimmunity, or there can be a vascular insult. For example, Sheehan syndrome, that is in postpartum hemorrhage due to hypotension, blood supply to the anterior pituitary becomes low. So because of that, pituitary can go for necrosis. So vascular reasons can be there. Or there can be iatrogenic or surgical removal. Example, parathyroid gland can get removed during thyroid surgery. It's an iatrogenic hypoparathyroidism. So the next is congenital. There can be some genetic deficiencies. So these are some reasons why a hormone has to be low. What are the reasons why a hormone has to be high? Again, there are some congenital or genetic reasons which increase secretion. The most important thing is adenoma or hyperplasia. That is a tumor. A tumor which is functioning is the reason for hyperproduction. Adenoma or hyperplasia. So this is one basic which will help us to understand. So if you are discussing acromegaly, what may be the reason? A pituitary growth hormone secreting adenoma. So what may be the reason for prolactin excess? A prolactin secreting adenoma, prolactinoma. So this is a Harrison's approach to elevated prolactin levels. Please remember, prolactin is not only caused by excess prolactin, or the prolactinoma is not the only cause of hyperprolactinemia. There are many causes, because just even a nipple stimulation can cause hyperprolactinemia. Just a chest injury or one disease which occurs in chest, herpes zoster, just these diseases, by stimulating the mammary area, that can increase prolactin secretion. There are some drugs we discussed, drugs which inhibit dopamine, so anti-dopaminergic drugs. These drugs can increase prolactin. So prolactinoma is not the only cause for hyperprolactinemia. So whenever a scenario comes, prolactin level is elevated, especially when it is mildly elevated. For example, if you say 40 nanograms per ml is the normal level, up to 500 there can be benign causes. But more than 500 or more than 1000 definitely indicates some pathology like prolactinoma. That is what is given here. There are so many secondary causes for hyperprolactinemia. They have to be ruled out. Only then we have to think of prolactinoma. So how will you think of prolactinoma? You can do MRI brain and we can measure the prolactin levels, right? How will you treat? By giving dopamine agonist. There are two dopamine agonists, cabergoline and bromocriptine. Now consider this scenario. Pituitary sits in a part of the brain called as cella. So pituitary adenomas are usual causes of cellular masses. So when the mass increases, what all can happen? In front of the pituitary, the optic chiasm is there. So when the optic chiasm gets compressed, there can be bitemporal hemianopia. This is usually discussed in ophthalmology. There can be bitemporal hemianopia. There can be headaches. So a mass in the cellular or cellular mass, especially any adenoma, causes hormonal problems, plus they also cause local compression problems. Example, bitemporal hemianopia. Remember, in prolactinoma, this is again a picture from Harrison. You can see how big the cellular mass is. In prolactinoma, since it is a highly hormone sensitive or a drug sensitive tumor, even though the mass is very large, it can be suppressed by medicines, dopamine agonist. We consider surgery only in few selected situations. That is, one, there are some mechanical effects. For example, there is bitemporal hemianopia. Next is prolactin levels remain high during follow-up. Or tumor continues to grow despite treatment. Tumor growth. So some scenarios usually will be kept in the exam about differentiating hyperprolactinemia, secondary causes versus prolactinoma, or a prolactinoma, how will you treat, right? If there is a mass which is not hormone sensitive, then there is no point in giving a dopamine agonist. Just a cellular mass without elevated prolactin needs surgery. But high prolactin level, but it's not causing any compression, even though the cellular mass is large, we can treat it with medicines. Okay, we'll stop here because not to get confused further. So we discussed about growth hormone and we discussed about prolactin. Now coming about adrenocorticotropic hormone. So these two hormones which we discussed till now, the growth hormone and prolactin, they are standalone hormones. They do not act on another endocrine gland. Like prolactin acts on the mammary gland, that's its end organ. Growth hormone acts on all parts in the body, that's its end organ. It does not stimulate or it does not have any influence on another endocrine gland. Whereas ACTH is one hormone which acts on another endocrine gland, which is adrenal cortex. That's why adrenocorticotropic hormone. ACTH acts on adrenal cortex. In this juncture, we will discuss two terms in endocrinology, which is primary and secondary. So what is primary in endocrinology is anything which deals with the primary endocrine gland is primary. For example, there is an excess or deficiency due to a pathology involving the gland itself. What is secondary? Secondary is excess or deficiency due to, it's not due to the gland problem, but it's due to a pituitary problem. For example, we'll discuss primary I'll tell a simple thing as primary hypothyroidism. What is hypothyroidism? Low thyroxine secretion. What is primary? The problem is with the gland. So the thyroid is problematic. It does not secrete T3 and T4. What is secondary hypothyroidism? T3, T4 is low, but it is not due to a problem in the thyroid gland. It is a problem in the pituitary. So what is the sequence here? Pituitary is problematic. So TSH is not secreted. So T3 and T4 is not produced by the gland. Right? This is the sequence in secondary hypothyroidism. What is meant by primary hypothyroidism? TSH is secreted normally, but the thyroid gland is problematic due to some reason. So thyroid gland does not produce T3, T4. But the adrenal, the pituitary is normal. So when T3, T4 is low, what happens? Feedback occurs, TSH tries to increase. Right? So that is the term about primary and secondary. I'll give you another example. Addison's. I told Addison's is cortisol deficiency. Cortisol is so when cortisol is deficiency, it may be due to primary Addison's secondary additions. So what does primary additions means? Cortisol is low due to a problem in the gland itself. So the pituitary is normal, but there is some problem in the adrenal gland, so cortisol is not getting secreted. What is meant by secondary additions? Same thing, cortisol is low, but it is not due to a problem in the adrenal gland, it is a problem in the pituitary. So ACTH becomes low. Since ACTH becomes low, cortisol becomes low, right? So this is about primary and secondary in endocrine. So now we'll go about ACTH excess. So when ACTH is excess, what will happen? Cortisol will increase. I told you there is no connection between ACTH and mineralocorticoids. Only cortisol is increased by ACTH. So when ACTH is in excess, cortisol will be more. So we call it as primary Cushing's, or they are given another term for that. That is ACTH dependent Cushing's. Okay, ACTH dependent Cushing's, or older terminology it was called as Cushing's disease. Okay, so these symptoms you must remember for scenario discussions. Like there is obesity, moon face, hypertension, diabetes, purple skin striae. This is very important. Purple striae, moon face. This purple striae will not occur in hypothyroidism. Moon face can occur in hypothyroidism and cortisol. And proximal muscle weakness, obesity, acne, bruising, some mental changes can be there. Okay. So we will discuss about this sometime below also. Okay. So we are discussing about hypopituitarism and pituitary excess. So we discussed about two important hormones, growth hormone, prolactin, what happens in its deficiency, what happens in its excess. And about Cushing's we are discussing, it is about cortisol excess due to, it's due to cortisol excess, either due to pituitary problem or due to gland problem. So we are going to discuss that again sometime down. We are not discussing gonadotropins now. Now we will go to the posterior pituitary hormones. So as discussed, there are two posterior pituitary hormones. Oxytocin we will not discuss today. We will discuss about vasopressin. Vasopressin is also called antidiuretic hormone. So antidiuresis means it reduces urine output. Means it reduces water excretion by the renal tubules. So this is the normal kidney. Concentrate on the last portion, the collecting duct. So vasopressin, what does it do? It acts on the V2 receptor in the basolateral membrane of the kidney tubules, of the collecting tubule. So when vasopressin acts on the V2 receptor by downstream mechanism, it causes expression of aquaporin 2 in the apical membrane of the collecting duct tubules. So what happens when aquaporin 2 gets expressed? It reabsorbs more water from the collecting tubule. So vasopressin acts on V2 receptor in the basolateral membrane of the collecting duct to increase expression of aquaporin 2 to cause reabsorption of water from the collecting tubule into the blood again. It is only water, it is not sodium. So when vasopressin is more, what happens? More water is absorbed. When more water is absorbed, what happens in the blood? What happens in the urine? When more water is absorbed, the blood becomes dilute. So dilute blood will cause hyponatremia. When more water is absorbed, what will happen to the urine? Urine will become concentrated. So urine osmolality will be high. So urine osmolality will be high, but blood will become dilute. So blood osmolality will be low. So usually they say values. Urine osmolality can be higher than 300 milliosmoles. Blood osmolality will be less than 300 milliosmoles. There will be hyponatremia in the blood. Okay. So when urine becomes concentrated, usually you can say there will be oliguria, concentrated urine. So this is about vasopressin. So vasopressin controls this. So this is about when vasopressin is more. What happens when vasopressin is low? When vasopressin is low, water is not reabsorbed from the collecting tubule. So what happens in urine? Water is not absorbed, so more water is excreted. When more water is excreted means urine is dilute. So urine osmolality will be low. They say it's usually less than 150 milliosmoles. What happens to the blood? Blood will become more concentrated. So there can be hypernatremia. When hypernatremia is there, thirst will come. So this vasopressin excess is a disease called as SAADH, syndrome of inappropriate antidiuretic hormone. Vasopressin deficiency is a disease called as diabetes insipidus. Okay. So that is about SAADH. So if you compare SAADH and if you compare diabetes insipidus, SAADH is due to inappropriate excess secretion of ADH. Diabetes insipidus is reduced ADH or reduced action. Where does ADH act? It acts on the V2 receptor in the collecting tubule. So either ADH can be low or ADH is normal, but its action on the vasopressin receptor is low due to some downstream genetic signal. Problems with downstream signal. So when ADH is high, what happens? There will be hyponatremia. Because more water is absorbed. And what will happen to the urine? Urine will be concentrated, so urine osmolality will be high. In diabetes insipidus, what happens? ADH is low or its action is low. So when antidiuretic hormone action is low, water is not reabsorbed. So more water is excreted, so it causes polyuria. That polyuria will be with dilute urine. So urine osmolality will be low. Will be low and there can be hypernatremia. Usually they say SAADH causes euvolemic hyponatremia. Remember, in hyponatremia, we can simply classify as three types. Hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia. Hypovolemic hyponatremia is there is a volume losing condition such as diarrhea, vomiting, and patient develops hyponatremia due to that. Euvolemic hyponatremia is SAADH. Hypervolemic hyponatremia, patient is having some volume overload conditions like cirrhosis, heart failure, CKD, etc. Likewise, they classify hypernatremia, hypovolemic hypernatremia, euvolemic hyponatremia, and hypervolemic hypernatremia. So diabetes insipidus is one cause of euvolemic hypernatremia. Now, what test do you do to confirm diabetes insipidus? Patient has polyuria. So, polyuria can occur on drinking more water. So, just remember, water deprivation test is the test used to confirm diabetes insipidus. So, what is expected? Normally, when we drink less of water, urine osmolality should increase and urine output should reduce. But in diabetes insipidus, already the ADH is low or its action is low. So when you do a water deprivation, patient's urine osmolality still remains low. That is, urine never becomes concentrated despite taking less of water. So urine osmolality remains high. So this is one test to confirm diabetes insipidus. Now I told you there are two types of diabetes insipidus. One is central diabetes insipidus, where there is actual deficiency of ADH, but its action on the kidney is normal. Another type is called as nephrogenic diabetes insipidus, where ADH is normal, but ADH action on the V2 receptor in the kidney is problematic. Now, how will you differentiate these two? Central diabetes insipidus, definitely urine osmolality remains high on water deprivation. But how does it improve? Since ADH is low, it improves with giving ADH. So a drug called desmopressin is there. It's a chemical form of vasopressin. So on giving a drug called desmopressin, urine osmolality becomes high. Sorry, I made a mistake. Urine osmolality remains low. Only if the urine osmolality remains low despite water deprivation, it's called diabetes insipidus. So urine osmolality becomes high on giving desmopressin in central diabetes insipidus. In nephrogenic diabetes insipidus, what happens? Urine osmolality remains low despite water deprivation, but even on giving desmopressin, the osmolality does not become high. So osmolality remains low despite giving desmopressin. So water deprivation test, if you deprive of water, if the urine osmolality becomes high, it indicates it is psychogenic polydipsia or it is not diabetes insipidus. If the urine osmolality remains low despite a water deprivation, it definitely means there is a diabetes insipidus. So how will you differentiate central diabetes insipidus versus nephrogenic diabetes insipidus? On giving desmopressin, if the urine osmolality improves, that is, it becomes high, it is central diabetes insipidus. If the osmolality remains low, despite giving desmopressin, it is nephrogenic diabetes insipidus. It's a problem with the vasopressin action. So this finishes the single post-repetitive hormone.